I'm Dr. Anjum Siddiqui, Senior Resident in Department of Clinical Immunology and Rheumatology at KGMU, Lucknow. I'll be presenting a case of focal myositis as a presentation of mixed connective tissue disorder. So our patient is a 30-year-old female without any prior comorbidities, and she presented with chief complaints of fever and swelling of left leg for the past 1 month. The fever was high grade to touch, associated with chills, undocumented, and it was associated of left leg swelling, which was acute in onset, painful and progressive to such an extent that she was not able to bear weight on that particular limb, and she was bedridden in a period of 10 to 15 days. On further history taking, she was found to have a history of Raynaud's phenomena, puffy fingers during winter, and sicca for the past 3 years. This patient was admitted in emergency medicine department, so they sent us a referral. So we attended the patient and then we further evaluated, and we found she did not have any prior history of trauma, discharging pus, travel, past history of tuberculosis, prolonged immobilization, pregnancy loss or morbidity, previous venous or arterial thrombosis, lymphadenopathy, rashes, inflammatory polyarthritis, shortness of breath, oral genital ulcers, skin thickening, gangrene, and digital ulcerations. With this history in our mind, we started doing the examination. On general examination, she had normal vitals, pallor was present, and she had clubbing. Along with that, she had cuticular overgrowth with periangular erythema on the nail beds of all her digits. And since she had sicca, we did perform a Schirmer's and unstimulated salivary flow rate, which was also normal. She did not have any digital pits or digital ulcerations. On local examination, there was diffuse erythematous swelling involving left foot extending up to the knee with local rise in temperature and tenderness, and there was no overlying draining sinus, abscess, dilated vessels, or rash. In systemic examination, she had fine inspiratory crypts audible in bilateral infrascapular and infraaxillary region, no evidence of pH or any focal neurological deficit in CNS examination, and abdominal examination was also within normal limit. With this, this is a pictorial representation of the clinical features. The first image is showing the cuticular overgrowth and periangular erythema. The second depicting the clubbing. The third is clearly showing the diffuse, tense, non-pitting swelling of the left lower limb. So with this symptom complex examination in our mind, we did further workup. Her hemoglobin was found to be 10.8 with elevated TLC, elevated ESR and CRP, and OT more than PT, OT of 65. Rest of the workup was negative, including blood cultures, dengue serology, scrub, leptospira, and malarial antigen with normal electrolytes. So we did consider she had an underlying CTD along with possible differentials of cellulitis and DVT. So we started the patient empirically on antibiotics and anticoagulation. And with this possibility, we did further workup, but on her USG, there was no vascular abnormality, no evidence of DVT, only mild edema over left calf and foot. But we were not convinced. We went ahead with color Doppler. It also did not show any evidence of thrombus, and CT venogram was also normal. And despite 5 days, she did not have any improvement, and all her infective workup, which we had done, was negative. So what were the later possibilities? We checked out the bony compartment. It was also normal. So we went ahead and did a MRI of her left leg. So this is a T2 weighted stir fat suppressed sequence. We can clearly see there is hyperintensity noted in the posterior compartment of leg. The same depicted in the other cut and the sagittal sections. So we kept the possible differentials of pyomyositis, rhabdomyolysis, and focal myositis and did the further workup. Her CPK was 751. LDH was also elevated. Urine for myoglobulin was negative, with normal potassium levels, and there were no focal collection on the imaging. Hence, the diagnosis of focal myositis moved up. On further autoimmune workup, we found her ANA to be 3+ nuclear cold spectral. ENA had RNPSM 3+, Rho52 3+, SSA 1+, low C4, normal dsDNA, UNRP 2 times upper limit of normal, and APLA was negative. We further went ahead and did a muscle biopsy. It was consistent with focal myositis. So myositis or myocytes of variable size with focal endomysial and facial infiltration by macrophages, which were CD68 positive on immunohistochemistry. We started the patient on 1 mg per kg steroid. Then, since the patient had fine inspiratory crypts on examination and patient was fitting in into MCTD category, so we did our HRCT. It shows diffuse GGOs and septal thickening. classically consistent with ILD of NSIP pattern. On further workup, we looked up for erosions which were not present on her X-ray. On pulmonary function test was also normal. Echo showed evidence of mild PAH with normal ejection fraction, no evidence of pericardial effusion or valvular abnormality. And carotid was also normal. So, with her symptom complex of RP, Zika, interstitial lung disease, focal myositis, and her autoantibody profile in ENA, elevated U and RNP, and mixed connective diagnosis of mixed connective tissue disorder was made. We started the patient on 1 mg per kg steroid, and she had ILD along with myositis, so we choose MMF as a second-line agent. After 1 month follow-up period, patient had significant improvement in the edema and now was able to move and walk around with minimal support. This is the image of the patient after 1 month follow-up. So as far as MCTD goes, 90% of patients have some degree of myositis. It may range from normal elevation of CPK and asymptomatic, patient being asymptomatic, or it could be frank myositis. Also, focal myositis itself, when we reviewed the literature, only 250 cases had been reported so far. And out of that, 34% of patients were related to some or the other immune-mediated disease, most commonly associated with either idiopathic inflammatory myopathies or by Behçet syndrome. CTD is coming into last. With MCTD as a cause of focal myositis, I could only find a single case involving the neck muscles. So my take-home message is that it is extremely rare and needs a very high index of suspicion. And whatever management we could do, it is on the basis of pre-existing guidelines. Because with so less number of patients, the guidelines are mainly directed toward the overall disease, and focal myositis research is less done. And it is mostly associated with IMs, followed by Behçet and CTD. It is in general, per se, it presents like a pseudo tumor, and in most of the cases, it resolves spontaneously. But when it is associated with autoimmune diseases, along with raised inflammatory markers, elevated CPK, painful, and had a relapsing or persistent course, then it warrants immunosuppressive therapy. What kind of therapy is to be given? It depends on the underlying etiology. And prognosis varies as per age, underlying etiology. Hence, close follow-up needs to be done for development of other manifestations. Thank you.